Welcome to UOA On Demand. I'm Dr. Stephen Kayiaros, a joint replacement specialist here at University Orthopaedic Associates. Joining me today is my friend and fellow joint replacement specialist here at UOA, Dr. William Baione. And today we're going to be talking about sporting activities after hip and knee replacement surgery, which is a common question that we get from patients. Our patients today are much more active than what they used to be, whether that's playing golf or pickleball, which is quite popular nowadays, or even more vigorous activities such as tennis or skiing. But we do get a lot of questions about patients as to whether they can resume those activities or when they can safely resume those activities after hip and knee replacement surgery, and specifically in regards to whether the implant is going to be able to withstand that kind of activity. So Will, maybe you can start us off here by telling us how you start that conversation with the patient and kind of how do you counsel people through that discussion?
I think that's a great question. It's probably the most important question, and it comes down to kind of understanding your patient. They come to you with the problem that they think you can fix. And so I think establishing the appropriate expectations is probably critical to how they're going to respond to the surgery. I think first of all, you have to determine whether or not they actually need the operation. And what that comes down to is, do they actually have arthritis? And do they have the symptoms that are associated with arthritis? And so you may have, two groups of patients. You'll have a patient that has a severely arthritic joint that has radiographic arthritis on an x-ray, is very limited in everyday life, can't perform their activities of daily living, can barely walk. That's one type of patient. And then you can have another patient that is otherwise pretty active, is able to do most things, but really only starts to experience symptoms when they start to push it or when they do more strenuous things. And so you'll have patients that will report that they ride, 5 to 10 miles a day on their bike and they walk several miles. But they may also think that they need a joint replacement. And so I think diagnosing them appropriately, but then understanding their expectations, because patients want a shorter recovery. They don't want to have a lot of discomfort post-op. They want relief and improvement in their overall mobility. They want to know if they're going to be able to do things that they're not currently able to do. And I think the 21st century patient that we're dealing with now is not the same as the patient that we had, 25, 30 years ago, where a lot of patients really expect to be able to get back to everything without restriction. And I think if you don't identify what the patient is trying to do, even if the surgery is successful, they may be unhappy. So I think really understanding the patient and getting down to why you are performing this surgery is critical.
Yeah, I couldn't agree with you more. I think, like you said, getting a sense of exactly what patients want and what they're expecting, and then setting those expectations and tailoring them to the patient is critical, so that they, number one, have a good outcome, and number two, they're satisfied with the outcome. So maybe let's talk about the patient who comes in. They know they need a hip or a knee replacement. They're currently very high functioning, and they want to know, basically, the $64,000 question is, when am I going to be able to do X after the surgery?
So I think that's a question, again, related to what the patient plans on doing. And I think there's I'll call it a philosophical difference, or, some practitioners just have a certain way of practicing where they'll say, look, you're not allowed to do these things. And so whether that's based on truth or experience or how they trained or hearsay, I think the literature and Google and how doctors practice is a little bit muddy. So again, in my understanding, if you're going to be doing a hip or a knee replacement that uses polyethylene as part of the bearing, I think the concern is always that if you engage in repetitive high impact activity, you're going to theoretically wear the joint out sooner. And I think there's some literature that kind of explores that, and we can talk a little bit about osteolysis and how that affects joints. But in terms of when they're allowed to return to activity, I kind of divide it into my hip and my knee patients. We both do anterior hip replacements. It's a muscle sparing total hip with no major postoperative precautions. And so patients are usually feeling pretty good early on. And the one thing that I tend to advise people is that this is the time where they feel a little too good. They've been suffering with that arthritic hip for a long time where they could barely walk. And now they want to go to the gym and take a class, and sometimes that could be within a few weeks of the surgery. And what I advise them is that, we replaced the joint, but we didn't give them new muscles. And so they can injure themselves, not specifically breaking the replacement, but they can pull something or tweak something, and then they'll take a step backwards. So I often tell people that you want to wait at least, 2 months before you start doing anything even remotely strenuous, because you want to get past that initial inflammatory response. And, in the age group that we operate on, a lot of people are interested in golfing. And, golfing is one of those activities that has a lot of twisting and torquing. And if they're not ready, then they're going to go play, and then you're going to get a call about it, that they felt like they pulled something's wrong, and they might precipitate a little bit of bursitis. So I tell people to take it easy. And when it comes to the more athletic activities, I really find that people hit their stride somewhere between like 3 to 6 months. Like they'll just feel like all of a sudden, like they're just going about their activities, and something normal that might have hurt them in the past, they almost forget they had the replacement. And I think when you get to that point, and when you talk about athletes and trusting your body and understanding where your feet are in space with certain activities, I think the body has to recover related to the joint replacement. So I always say focus on the walking and the activities first, and then some of the sports and things can come later. Things that I will typically allow people to do early on, even during the initial therapy, are things like the stationary bike, the elliptical machine.
Yep.
These are sort of lower impact exercises that not only help with range of motion, but give the patient the sense that they're working out and making some progress. But I usually don't allow, sports, within the first 2 to 3 months if they ask me. Now, patients sometimes will do whatever they want, which is a different story, but, we can save that for another time.
Yeah, I mean, I think for me, it definitely depends on whether they've had a hip or a knee, and I agree with you, and it depends on what the sport or the activity is. I've had, I think for hips, I think because of the anterior approach and because we're not cutting muscles, I think those patients in general, we kind of let them get back to doing things a little bit sooner than knees. I had one patient, who played 18 holes of golf like a week or two after a hip replacement. I think that's the exception, not the rule. But generally, like by a month, if they're feeling okay, I'll let them go to the driving range and take some swings. And if they feel okay, I tell them maybe play 9 holes and see, with a cart, and see how it goes. I think, for knees, I think it's a little bit longer just because it's the knee is a bigger joint. It's more susceptible to swelling and inflammation. And I think if letting those patients get back to doing stuff a little bit sooner can sort of aggravate things. I totally agree with you with the stride time frame of 3 to 6 months of when patients kind of really feel good, certainly for a hip, and certainly right after 3 months for knees as well. Anything that we would consider quote unquote high impact, whether that's skiing or tennis, or maybe some pick up half court basketball. I think activities like that, for me, it's a minimum 3 months before they can do that, and they really have to be pain free before they try to attempt those activities. I think talking you had mentioned about the literature and about sporting activities. I think the literature doesn't really give us a good guide. I think there's no real good study to say, well, if patients do X, then their joint is going to wear out sooner rather than later. It's definitely a theoretical risk, that a high impact activity will put the joint through more cycles, and then more cycles will lead to more wear and possible loosening or osteolysis of the joint. The flip side of that is that the data on the implants that we have is so good now with highly crossing poly, where I'm seeing patients now that I operated on when I first started almost 10 years ago, and radiographically their joints look pristine, which is really incredible. So I think I tell patients I discourage high impact activities such as running and the sort, because it could lead it to wear out sooner. But having said that, I think if patients feel really good, I think they're gonna be active and do what they want to do, which I think is a good thing. And because we're always promoting motion and keeping the joints in motion and being active, because that has so many other benefits to our health.
I think that's a great point. The adage, like you said, we're operating on much younger people now, and it's not that we're more aggressive than the surgeons prior, but the prior generation had to deal with the materials that they had available. And once you started to perform joint replacements on people in middle age, be it in their late 40s or their 50s, with plastics that weren't as good, I think you would wear them out, and you would commit a patient sometimes to having 2 or 3 operations in their lifetime. The fact that the materials have gotten better, I think, allow us to safely implant these things in younger people and expect that it's going to last longer. So my question to you, you've had those patients that come in and they've been told by someone that they need to wait until they're 10 years older than they are now, but they basically have severe arthritis now and radiographically severe arthritis, and they're debilitated. And so the traditional bearing surface that we talk about is, plastic with either a metal or a ceramic head. What do you think the role is of some of these alternative bearings? And, we can explain that for the audience in terms of some of the other materials that are available, and what's your opinion about them, and whether or not they're an option for a joint if you're considering doing one on a young person.
Yeah, that's a really great question. So generally speaking, I will not tell patients that they have to wait until they're at a minimum age to have joint replacement, as long as they have obviously significant radiographic disease and they're debilitated by their ailment. I think for me, for the ultra young patient, and for a joint replacement, I would say ultra young is anyone under the age of 50. For hip replacements, I will discuss a ceramic liner with them. And with the advantage that the ceramic liner will not wear as the plastic will, and so it has the potential to last longer. The downsides, obviously, as that the liner could chip or it could fracture, and that's catastrophic because that's like an emergency revision, and it could generate some noise or some squeaking when they walk. So for me, it comes down to deciphering what's most important to the patient. If it's being active and not worrying about something happening to the implant, I recommend polyethylene, because it's true, it's tested, it works, it's resilient, and it can withstand a lot more, obviously, in terms of activity and impact than a ceramic liner could. If what's most important to them is longevity of the implant, well, then I would recommend ceramic liner, and telling them that they really cannot do high impact activities with a ceramic liner, because something catastrophic could happen. I think running, and what I mean by running is if you're routinely doing like 5Ks, 10Ks, running at least 3 miles a day, that's a runner. And so I think that type of activity, regardless of the bearing surface, is potentially problematic. In the short term, I think it's probably fine. It's kind of the long term that we kind of worry about. So I tell patients that if you had to run across the street, or run to catch a bus, or, God forbid, if someone was chasing you, you could probably run. But, I don't really recommend engaging in sustained running over long periods of time, because again, we just don't know what that is going to do to the longevity of the implant.
Another thing that I think is interesting, if you look at the evolution of implants and you look at where hip replacement started, initially cementing both sides of the joint, then eventually having a lot of failures of the cup, and then going to cementless implants. And as the implants have evolved, for the most part, even though there's, an acceptable solution for cementing, femoral stems that have a good clinical track record, a lot of arthroplasty, especially in the United States, has gone towards cementless fixation. I think there's some promising results in terms of short and midterm results of cementless knee replacement implants. And when you look at some of the reasons that knee replacements fail, specifically aseptic loosening on the tibial side of the knee, when you couple these higher impact activities with a traditional cemented implant, I think that those stresses that you're placing across the cement mantle likely increase the chance of loosening or failure of some of these implants. And so the coupling of the new plastics with now better cementless knee replacements, I think, might help us allow these patients to perform these activities when otherwise you might have discouraged it. I don't know what your experience is with, cementless knee replacements, but I think some of the literature and my current experience in practice has been promising with it so far.
Yeah, that's a really great point. I totally agree with you. So, obviously, you could tell me better than I could with your engineering background that, biomechanics across the knee is different than the hip. And so with high impact activities, since most of our knees are cemented, if they get like a little microfracture at that cement bone interface, it's not going to remodel. The cement is kind of permanent. It functions as a grout. But with a cementless design, there's constant remodeling around the implant. So if something something such as high impact activities, the bone can continually remodel around that implant. And I think, the short-term data on modern cementless designs, I think is very, very promising. And I think that's here to stay. And I think there were problems historically with prior designs on cementless knees and the technique not being able to be duplicated routinely. But I've been using now a couple different cementless designs now for the past couple of years in selected patients, usually younger and who want to be more active. And I've been very pleased with the outcomes thus far. But you bring up a very good point about, activity level and cementless versus cemented designs. We sort of take that for granted in the hip because we're essentially almost 100% cementless now on the hip side. I think just now on the knees, we're starting to, probably do more and more of cementless implants. I think, 5 years from now, it could be even percentage-wise, it could be even more, as long as the data continues to show that the survivorship on these newer, more advanced implants continues to be good.
Another option that isn't really available on the hip side but comes up with the knees is what's the role for partial knee replacements instead of totals in patients that maybe have that particular pattern of arthritis, and then for the purpose of our discussion, does that affect the activity level? Like, do you treat a uni any different than a total in terms of what you allow them to do or not allow them to do? What's your experience with that?
Yeah, that's a really good point. I think partial knees in general, at least clinically, they pretty much behave like a normal knee, and I think there's pretty good literature to support that in partial knee replacement patients can be more active and have higher activity, like UCLA outcome scores and patient-reported outcome scores than total knee replacements. And even though they do have an implant, they have their cruciate ligaments, they have two other compartments of the knee which have not been operated on. And so, I don't really restrict patients with a partial knee replacement. And I think I think you use the Oxford, if I'm not mistaken, which is what I use. And that implant now has like 30+ year data, which is, it's tough to argue with that data, with the survivorship being persistently and consistently above 90%, which is phenomenal.
Yeah. And I think at some point, not available in the US, but I foresee that some of these cementless unis will hit the market as well, because again, when some of the partial knee replacements tend to have early signs of failure, it tends to be around where the cement sticks to the implant. And so this is where it goes back to the higher impact activity, where if the cement's only acting like a grout and you're pounding on it and you get one of these micro fractures in the mantle, then that's sort of the beginning of what could be early loosening, where if you avoid the higher impact activity, I think the implant can last for a very long time. And that's always our worry. We don't want to restrict patients from doing the things that we enjoy, but on our end, we know what a revision entails. And what sometimes patients don't understand is that the second and the third time around can often be more complicated. And if we can avoid some of those issues, then that's sort of where we're coming from with trying to get people to at least be cognizant of the decisions they're making. Sure.
Now, let me ask you this, what about activities such as yoga or, Pilates or low impact or aerobics or other types of sport, particularly yoga, because we have a lot of patients that do a lot of yoga who are going to want to do various positions that are going to, like, let's say for a hip replacement, potentially put the joint vulnerable for dislocation. Like, when do you tell patients you're safe to go back to the yoga with no restrictions on positions?
Yeah. So again, for an anterior hip replacement, in the initial recovery, I don't usually place formal restrictions on the patient, but I often tell them that even an anterior hip is not impossible to dislocate. And so some of the early motions that you'd want to avoid are hyper external rotation, sort of a deep kind of lunging activity. After we get out of that initial phase of the recovery, usually after about a month or 6 weeks, if they wanted to get back to things, I don't personally restrict them. I just tell them that in the beginning, while the capsule and everything's healing, to not test the water. I think the concern sometimes comes with approaches and the healing of muscles, but I've found that at least with the anterior hip, it really hasn't been a problem for me in my practice. And I have plenty of patients that get back to yoga and Pilates and things, and instability hasn't been a big problem for us.
Yeah, I totally agree with you. I think anterior approach has certainly allowed us to be more lenient, or I guess, I don't know what, less restrictive, so to speak, just because it is very stable. As you said, it's not, the risk of a dislocation is not zero, but it is very, very low. And so I think once they're out of that kind of initial kind of 6-week time frame where soft tissue healing is starting to consolidate, I'll let them go back to doing, what they were doing before the surgery.
Yeah.
Well, I think that was a really good discussion on sporting activity. Will, thank you for joining me tonight here on UOA On Demand, and thank you everyone at home for joining us as part of our UOA On Demand series. If you have an orthopedic ailment or injury that you would like to have comprehensive evaluation of, or if you think you may be in need of a hip or knee replacement, please visit us at www.uoanj.com. Thanks so much and have a great night.
Thank you. Have a good night.